and welcome to our live webinar on COVID-19 Perspectives in Ophthalmology, organized by the College of Ophthalmologists and supported by the Academy of Medicine Singapore. I'm Dr. Leonard Yip, Honorary Secretary of the College of Ophthalmologists and Senior Consultant at the Department of Ophthalmology, Tan Tock Seng Hospital, and I'll be your chairperson this evening. Before we begin, let me just highlight to you some basic housekeeping rules. First, all participants will be muted to enable the speakers to present without interruption. Second, this webinar will be recorded. Third, for local doctors, please note that participants who complete the full session will be accorded 1 CME point after the event. There will also be a Q&A session at the end of the presentations. We'll be addressing some of the questions received earlier via email, but you may also send your questions via the Q&A option at the bottom of the screen. Today, we are pleased to have with us a panel of ophthalmology specialists who share their expertise and insights on the topic COVID-19 Perspectives in Ophthalmology. We live in unprecedented times, and we are all grappling with how to maintain access to ophthalmic care while protecting our staff and our patients. Our first three speakers will be sharing how their clinical practice has adapted to COVID-19. The first lecture is Ophthalmology Key Responses to COVID-19. Without further ado, I shall now welcome our first speaker, Dr. Louis Lim, Senior Resident at the Department of Ophthalmology, Tan Tock Seng Hospital. Dr. Lim.
Thank you, Dr. Leonard. Good evening, fellow colleagues. I'm Louis from Tan Tock Seng Hospital. The SARS-CoV-2 is a novel RNA virus that was first sequenced in January 2020 and was responsible for a series of pneumonia-like cases in Wuhan, China. Currently, the number of people infected numbers about 3 million people, with the mortality about 200,000. There are currently no effective treatment nor any effective vaccine available. The full clinical spectrum of disease due to SARS-CoV-2 has not been established, and new case reports emerge daily that affect possible organs apart from the respiratory system that is affected. Conjunctivitis remains the most widely studied ocular condition in COVID-19 patients, with the current state of evidence suggesting that ocular transmission is possible, but not very common. There are two likely routes of transmission in the ophthalmic practice. First, contact with infected ocular tissue, for example, in patients with conjunctivitis, as well as droplet transmission, which is a more likely source of infection due to close proximity of our patients' nose and mouth, as well as contaminated surfaces. Uniquely, in ophthalmology, we have a high patient load, as well as a unique practice requiring routine use of reusable equipment in close contact with patients, such as the Goldmann applanation tonometer, as well as many high-risk, high-touch surfaces, such as the slit lamp, as well as imaging devices. Contaminated surfaces are key sources of iatrogenic transmission as well. Tan Tock Seng Ophthalmology also accepts inpatient referrals from both NCID as well as Tan Tock Seng general wards. And the movement of patients and ophthalmologists to and from these wards and eye center poses a significant means of cross-infection between wards as well as between outpatient and inpatients. There is also a high surgical and procedural caseload and turnover for both inpatient as well as outpatients. Hence, similar to the inpatient movement, there is a high risk of transmission between community and healthcare workers, as well as patients and healthcare workers from different wards and different departments. Hence, with no effective antiviral treatment available and no effective vaccine to be widely available in the near future, healthcare infrastructure should be directed at enhancing detection of cases and minimizing transmission risks at all fronts. Hence, my fellow presenters and I will be going through a set of good ophthalmic practice guidelines in the following sequence. We're going through infection control, staff protection, screening of patients and visitors, as well as inpatient care. Dr. Loon will go through outpatient care, surgery, as well as resilience and mental well-being. While Dr. Kaur will go through logistics, manpower, workplace social distancing, as well as communications. With regards to infection control, ophthalmic equipment are easily contaminated with respiratory droplets, tears, and conjunctival secretions of infected patients. Left unattended, this serves as hotbeds for virus contamination. Routine cleaning significantly reduces environmental contamination. Based on a review of studies on human coronaviruses, we recommend the following antiseptic or disinfectants, such as povidone iodine, as well as most alcohol-based solutions, such as isopropanol and ethanol. Of note, some commonly used agents formulated with only quaternary ammonium compounds or phenolic compounds, or a combination formulation of only chlorhexidine with cetrimide were found to be ineffective against human coronaviruses. We also strongly suggest the maintenance of strict hand hygiene during clinical care, as well as the increase of frequency of cleaning of high-touch surfaces during the day, including chairs and tables, door handles, as well as keyboard and the mouse. We should also ensure proper decontamination of ophthalmic devices and optical surfaces after each use. This can be done by reviewing the product inserts for each device to determine the most appropriate cleaning method, as well as to ensure that the recommended cleaning agent is effective in disinfecting COVID-19. In Tata Singh, we have also ceased the use of air puff to measure IOP to prevent the generation of aerosols from infected conjunctival secretions. The indication for use of personal protective equipment or PPE and the level of PPE to be used should be clearly documented and circulated to all staff. Refresher training for all PPE, as well as repeat and documentation of fitting of N95 masks, if not done within a year ago, should also be carried out. Compliance to these PPE guidelines are mandatory for all staff. Staff are also to perform twice a day temperature taking and reporting, and staff who are unwell with fever and or respiratory symptoms should report to their heads and send to the appropriate medical facility. Influenza vaccination is also strongly encouraged for all staff to avoid clusters of fever due to other infections as well as unnecessary quarantine. The following slides will show sample PPE recommendations for healthcare workers in Tan Tock Seng Hospital. However, in general, when reviewing suspected or confirmed COVID-19 cases either in the isolation room or in the ward, we recommend the use of full PPE, which would include N95 mask, some form of eye protection such as goggles, full gown, as well as gloves, as well as a shower cap. These are some protocols that we have before attending to COVID patients in the ICU, as well as in the general ward. This is me in the NCID in full PPE with my medical officer. In the general clinic, I have my junior resident here who's showing that in our common practice, we will wear the N95 mask as well as goggles together with gloves when we examine our patients, as seen here. Proper triaging is important in a busy clinic to reduce the spread of disease and for contact tracing purposes. With the continued evolution of disease epidemiology, protocols have to be constantly updated to meet up with the newest developments. In Tan Tock Seng, we have established triage processes at both the hospital and the clinic entrance to identify patients and visitors at greater risk of COVID-19 infection. And this would include temperature check for fever, questionnaire on acute respiratory illnesses, travel history, close contact with a COVID-19 patient, or if the patient or visitor is under a home quarantine order or stay home notice. At the triage area, patients who are at increased risk should be considered, we should consider rescheduling non-urgent appointments, and visitors accompanying such patients should be turned away. Higher risk patients who require same-day consult should be seen separately in an isolation room and given a surgical mask if not already wearing one. Staff reviewing such high-risk patients should don appropriate PPE when reviewing. In Tan Tock Seng, we don the full PPE, which was previously mentioned before, and we should perform all examination in the same isolation room, minimizing contact time and cancelling or postponing any non-essential investigation or test. Single-use consumables should also be used for each review, and terminal cleaning after each review has concluded. These are some of our protocols. This is a protocol for the registration of high-risk patients. For patients who are high risk and still need to be seen urgently, they will be given an orange sticker and then sent to a pink room or isolation room. For the next of kin who are at high risk, we will deny them entry to the clinic and inform the next of kin to leave the hospital premises. If such patients or next of kin fall through the cracks and they end up in the consultation room, then the consultation room becomes a pink room and the room will be disinfected after use. For other waiting patients, they will be decanted out to other consultation rooms to be seen. With regards to inpatient care, in our department, we are reviewing patients in the bedside or the ward if possible and comply with all infection control and PPE requirements in the ward. We also will minimize transfer to the outpatient clinic and separate inpatient and outpatient care areas to minimize interactions. We also avoid cross-infection between different wards by arranging different time slots for each ward, as well as to ensure all cases are non-suspect cases and afebrile. This is the protocol that we have, as previously mentioned. And I would like to acknowledge these few senior doctors for the opportunity to speak for this webinar. And I will give my time back to Dr. Leonard. Thank you.
Thank you, Dr. Lim. To continue with this first lecture, I'll be asking Dr. Loon Seng Chee, Director of Clinical Services, Department of Ophthalmology at the National University Health System, to continue. Dr. Loon.
Thanks, Leonard. Right, I'll go straight on the areas that I'm covering today, which will be the ops side in clinics, surgery, and of course, mental well-being. Now, we've gone from this to this in a very short span of time. And looking at this chronological picture we got off CNA from the 7th of February all the way when DOSCON was declared to about the middle of March when we saw a rapid rise in the numbers. It has been a rather short time. And even prior to DOSCON Orange, we have actually started planning for cohorting and physical separations. In other words, in the National University Hospital as well as Alexandra Hospital, we actually have separate teams. In the main teams in NUH, there are mirror teams on both sides. So we have two teams that are similar in the number of suspects, as well as an additional smaller team in AH already separated out. Plus, we have separation of the staff who are pregnant as well. And we began separating and reducing the numbers in clinics and OTs. And credit to our doctors, the buy-in from the specialists and the seniors was actually excellent. And we developed a system for stickers and screening of patients even before the main hospital decided to do so. Gradually, with time, we've also worked in work-from-home procedures from the doctors and subsequently to our allied health and executives as well. One of the things we're really proud of, I guess, is the fact that the entire unit came together as two separate teams rather than by individual silos to work, so that we can cope with the changes that can come almost day to day. So with a consultant-driven practice, we are actually able to scale up or down in this case. And with the changes we've been able to deploy our medical officers and volunteers to places for screening, the dorms and so forth, and quickly meet the needs of the day because it is managed as an entire clinic. And we also have a system where one of the teams is basically on the on week where they are mainly in the clinic, and the second team has less clinical duties, so they can actually aggressively manage the patient list and review them so that we can downscale the clinic even when the order to cut the numbers are given quite suddenly. In addition, we also have our plans previously for telemedicine and virtual clinics, and we've been able to put them into action more quickly. This also follows on that we developed a rather robust appointment team, because it's very important that you close the loop for patients who now have their appointments changed at rather short notice, and also for the patients who default on the day itself. We must be able to close the loop for them, get their medication to them with via home delivery, or if they turn up at the pharmacy. We also have a color coding system, so that we can show our staff which are the areas that they should be aware of. For example, blue for the nurses here. And of course, in the clinic itself, we've really practiced social distancing. I think this is quite common across all the major hospitals. On the picture on the right, actually, we're developing an actual physical door between the two sections in our clinic, such that, and we actually duplicate the services, including machines like the HVF, OCT, and so forth, such that each team has their own essential equipment and can function totally separately. So if one of the teams gets hit by the virus, the other team can actually take up the duties and continue functioning independently. And obviously, I think we also made the entire team, including the allied health, very aware of the kind of suspect cases. And kudos to one of our senior registrars, David, who has devised his own clinic management roster system, where we have a system where we looked at the total number of patients that were coming in, and this is directly fed from SAP as well, so that we can actually see the load for the day and manage with contributions of manpower from all ranks. In fact, we actually made it understood to our own seniors that if the day comes, we'll have to do step-down calls, and everybody will be involved in that. So we also had a consultant screen out the cases and these were moved by the PCAs, with every change documented on CDoc as well, the electronic medical records. We have weekly updates at our ops meetings, and we also have chat groups that allow us to cope with the day-to-day changes to make it more visible to everybody. And we have this, which is actually on Google, so everybody is able to see his duties every day, even if it means that the changes are effected at the very last minute. Everybody can see it both at home as well as at work. So with regard to the cleaning, I think Louis has mentioned some of that. And so there are challenges for certain machines, like the HVF, for example. We actually went to the manufacturers, and they discouraged us from using alcohol to clean the bowl, which they reckon will damage it. So we're quite grateful that later on the government decided that everybody should be using masks, so that it creates a barrier in itself. We also consulted the ID physician. So we are cleaning the chin rest, and we're putting fans in the room to improve circulation. And I think Louis also mentioned the shields as well, and the use of tonopens and the disposable GAT tips. So I think in the OT itself, it's quite standard. The PPEs for aerosol generating cases. We use surgical masks generally for the rest of the cases. Our own nurses have been cohorting as well. And we've been looking at the list, compressing them. And right now, all non-urgent cases has been postponed. And the lists are approved basically by the clinical director or the HOD. And we've also put training on the back foot here, and there's none at the moment. So we move on to a slightly different area, and that's about well-being of our doctors during this rather stressful time. And actually, this is a painting done by one of our senior consultants, Dr. Ray Mantosh, during his spare time. So I think that way back about 17 years ago, I was probably the only ophthalmologist at one point in the SARS wards, and it's the isolation and anxiety I can understand from even this current disease. And learning from that, it's important to deal with a disease where right now we have more unknowns than knowns. The end point is difficult to know when it comes, and instructions are coming in almost on a daily basis. So there's a lot of anxieties that we need to understand that doctors as well as our staff are facing, which are not in the usual ophthalmology practice. So we need to find out what is evidence-based, deal with the anxieties and the unknown, and come up with rational responses that we can give to all our staff to help them to cope with the situation. And I recall the first time we met at the beginning of this when we were in different cohorts, and I mentioned that it isn't going to be a short couple of weeks battle when we are all back to normal. And there were a few crestfallen faces, and it's important to understand that dealing with a crisis where we don't see the end point yet, and now we also are sending volunteers into more difficult situations such as dorms for swabbing, which may result in these ophthalmologists now facing isolation from their families. There's also worry about the economy in general. and this general fear of what if they get this disease. And all this can lead to a lot of burnout. So being aware of these is very important. And the mental game. So a different kind of ventilation here is required, where you need your staff to be able to speak out, give them some R&R time. And the photograph on the right actually is one of us celebrating the birthday of one of the staff with a little cake. And that's the other side of the team coming together to do that. I think it's important to keep in communication with all the doctors as well as the other healthcare workers in your team, engaging them to make sure that they are well. And I think Tan Tock Seng also has a Spread a Smile campaign. And it's nice if one of my former students gave a whole care package to all of us to improve our skin. And of course, well-being of it's not only mental, but it's important to have physical well-being as well. And during this time when we are isolated and we may not have the capacity to go out, take care of our bodies. And whether we live with our families or especially for those among us who might be isolated, ways of decompressing via religion, friends, family, as well as colleagues. So there are avenues out there for us to seek help, and I think the seniors in every department will be able to point them to that. And I'm happy to take things aside later on to also discuss this with anyone who might have more questions on that. Just like to acknowledge a few of my team members who helped me with this, and also my eye department. And I think questions, I think we're going to take later. So back to you, Leonard.
Thank you very much, Sing Chi. To wrap up this first lecture, I'll now be asking Dr. Koh Wei Boon, Senior Consultant, Cornea and an External Eye Disease Service, Singapore National Eye Centre, to take the podium. Dr. Koh.
Thank you, Leonard, and thank you to the College of Ophthalmologists for inviting me to be part of this webinar today. So continuing on with the topic of key responses to COVID-19 in ophthalmology, I'll be speaking on the following topics about manpower, a little bit about logistics, something about workplace measures and communications. And this comes from me being at the Singapore National Eye Centre, so I'll give our perspective. For those of you who are not familiar with the SNEC, we are the largest public service eye centre in Singapore with 80 ophthalmologists, not including our fellows and residents, as well as almost 1,000 staff, nurses, allied health, such as optometrists, administrators, and of course, a lot of our researchers are from the Singapore Eye Research Institute, or SERI. Last year, we saw 340,000 outpatient attendances, had 26,000 surgeries, and we also provide services at 4 satellites, of which the largest, Changi General Hospital, as well as 2 community clinics. I'll start off with this picture of this bus here, which is actually a shuttle bus in SGH, the Singapore General Hospital. And on the sign, it says SGH Orange. I took this at 4 p.m. on the 7th of February, and I thought that's not a very good omen. And sure enough, an hour later, the Ministry of Health declared that we were going to raise the DORSCON from yellow to orange, and this marked really the first turning point in the COVID-19 pandemic in Singapore. So the first thing really was this idea of campus separation. And as you can see, we are a huge organization, and it was a big logistics issue to try and do that. What it meant was that we had to station staff only at one institution or campus, whereas you know our doctors and staff typically move from satellite to satellite within the week and sometimes even within the day. So we needed the satellites to be self-contained, as well as to continue the sort of subspecialty services that we had built up. In order to do that, we also had to buffer the satellites with enough administrative, nursing, and allied health manpower, because there would basically be no backup from the main center. So for example, we had to make sure that the Changi General Hospital had sufficient vitreoretinal surgeons, glaucoma specialists, oculoplastic surgeons, as well as residents to staff the calls and the services. The deployment of this staff outside to the satellites, however, left the main center with a relative shortfall in staff. And this was compounded by the fact that many of our visiting consultants and visiting anesthetists were not able to come to the main center anymore. As Xing-Chi has mentioned, we also had to prioritize and defer a lot of our non-urgent consultations and surgeries. We cut it down by about 50% of business as usual, and clinics had to be covered, redistributed. Some of the clinics, such as our LASIK clinics, were closed. OT lists had to be merged, and of course the doctors' rosters were all upended in order to cover all these services. And research and training, unfortunately, was all put on hold for this period in time. When you talk about manpower planning, of course, you also have to know how much manpower you have and where they are. So initially, there were leave restrictions. These have now been relaxed a little so that staff are allowed to take leave, but of course, no one can travel anywhere. And there is also a reporting process to track our staff who may be overseas. Initially, some of our staff were in mainland China. Some were in Malaysia, for example, when Malaysia declared the movement control order. Now, anytime you have a respiratory tract infection, you're automatically given 5 days of medical leave. So we have to keep close watch on that. And finally, for any staff that has a leave of absence, some sort of stay-home notice, or whether they themselves or even their families are quarantined, we of course have to know. I'll just speak very briefly about logistics. Fortunately, being in a public institution and in public sector, there is a whole operations department and structure to help us maintain that adequate supply of PPE. Nonetheless, at the clinic level, of course, we do need to be sure that we have sufficient types of N95 respirators, for example, since not every doctor can wear the same one. There has to be some sort of central control and distribution. Essentially, that means the nursing manager has to keep it under lock and key and distribute it at the beginning of the day. We also have to make sure that the supplies of consumables are stable, conserve medications and drugs, especially in OR. Although we are still able to perform surgeries, but there is an awareness that some of these medications are also used in ICUs. So if ICU use in the general hospitals increase, then some of these supplies may correspondingly have to decrease. A lot of the workplace measures that we've seen has been to limit the exposure amongst healthcare workers. If you remember from SARS, up to 40% of SARS victims or patients were actually healthcare workers. And with COVID-19, infection rates are actually very high in many countries amongst healthcare staff. I think Singapore, we've been very, very fortunate so far. But we've always been pressing on these two concepts of having a team A and team B segregation, as well as the idea of the social or safe distancing. And that effectively means we need to minimize our time with our surgical masks or N95 masks off. This photo shows you how we try to maintain that team A, team B split. So our staff will have name tags with little stickers, red and blue. And like Romeo and Juliet, they're not supposed to meet or else bad things happen. As a center, as in SNEC, it is very hard to physically separate our two teams. But so we try to minimize any intermingling between the teams. So we allocate where the staff have to work in certain areas or in certain clinics. For example, OTs have been split into two separate banks, and only surgeons are meant to go to one bank and not to the other. In order to facilitate all this, we've had to cater for extra break rooms, extra lockers for staff. And even if you're within the same team, you have to maintain safe distancing, 1 meter apart when you're communicating. If you have any meals with colleagues, you cannot be more than 1 or 2. Although now I think with the latest advice, everyone's been advised to basically have their meals alone. And again, this is to minimize any contact between staff when their mask is off. And of course, we no longer have meetings as a group. Everything is through web conferencing now. I think the latest milestone really has been our circuit breaker, all right? And for those of you who are in Singapore will know that the Prime Minister has basically said the circuit breaker is to make sure that everyone stays at home. And this has meant that although healthcare is an essential service, but not all services within healthcare are essential. There are restrictions on non-essential surgeries, for example, elective eye procedures, including cataract surgeries for stable cataracts. And we have had to reduce our workload and reduce our staffing to below 15%. So this means that basically all of us are working from home now. This means the need for virtual private network access. We are all handling sensitive data and information, and all this would have been impossible maybe even a year ago, shortly after the cyber attack on Sing Health. Of course, web conferencing allows us to continue to communicate, especially since our teams are now spread out in different campuses as well. And with the circuit breaker and the fact that now the workloads are well below 15%, SATC now has split the teams into 1 week on. That means one team will work in the center for that week while the other team will be off. I think the last topic on communications really is very vital in this COVID-19 pandemic. Events, even instructions have been changing so rapidly day to day, even within a few hours. And despite all our plans, things can change once we hit the ground. Issues on the ground need to be addressed, and there's always very good feedback when things are moving. And when times are uncertain, when things are uncertain, people, especially when people are worried, they need certain clarity and direction. So in order to cope with this changing events, communication has to be very clear so that we can coordinate action, encourage discussion and feedback, and more importantly, clarify, combat rumors, wrong information, like what I'm trying to allude to here in this picture. Within the Eye Center, of course, we do use instant messaging. The institution has insisted that we use Tiger Connect, which is an encrypted instant messaging chat group where the information is stored on our local Singapore servers. Other forms of communication, of course, are still important. Email is important to broadcast big chunks of information, social media for bolstering keeping spirits up. And of course, everyone is using web conferencing now, whether it's Zoom, WebEx, and so on. And this has allowed us to continue meetings, keep in touch with staff, hold town halls, of course, conduct teaching, as well, such as these webinars. I think the last thing I'd like to address really is that although things are still escalating in Singapore, the numbers are not really coming down too much. Doctors, nurses, allied health are now being called to the wards, to the dorms, and to the expo. Nonetheless, we've seen that, when people have a single point of focus, everyone can sort of step up and take on more roles and responsibilities. And it's also at this time that we've been able to push forward all these changes that we never thought would be possible. Not without huge committees, not without years or months, but we're making changes every day, sometimes within weeks, within days. So even in the midst of all this chaos, perhaps there is still an opportunity to make changes and push forward innovations that can benefit all of us in the future. I'd like to end up by saying that Singapore has, over this last month, trained an entire generation of children to web conference, okay? Not just the children, but parents and the grandparents as well. Now, if we could just teach everyone to take an eye selfie like I've done here when I was looking at my red eye, then I think tele-ophthalmology would really be a reality in the future. So I'd like to give thanks to Director Wong Tian-in, Edmund Wong, and all the other HODs, as well as all our SNEC and SERI colleagues and staff. And we'll keep the questions to the end of the webinar. Thank you, and back to you, Leonard.
Thank you very much, Wei Boon, for wrapping up the first lecture. For those of you who have joined late, there will be a question and answer session at the end of the presentations. Please feel free to send your questions via the Q&A option at the bottom of the screen. It's now my pleasure to invite Dr. Rupesh Agrawal, Senior Consultant, Department of Ophthalmology at the Tan Tock Seng Hospital, to deliver the second lecture. Its title is Ocular Manifestations of COVID-19 and Viral Transmission via Tears. Dr. Rupesh?
Thank you, Leonard. It's my opportunity and a real pleasure to speak to all of you. I can see 424 participants logged in and some of the panelists are there. I'll share my screen, and as we talk about it, I think this is a burning question, and already I can see the questions coming up related to this. Okay, so as I have very carefully put, as Vibhun has very clearly said, that things can change in hours, I have written here evolving literature. So there is nothing which is concrete and written currently which is cannot change tomorrow. So I will definitely like everyone to pay attention to this, is the evolving literature related to ocular manifestations of COVID-19 and transmission of virus through the tears. There are three particular questions which I'm sure all of you will like to know before we break for question and answer, or probably before we break for dinner. And this is the burning questions for last 3 months since the pandemic has set in. What are the ocular manifestations of COVID-19? Is it like Zika or some other virus, as work been done by Lun Sengchi in also for the SARS epidemic? Or how does it get transmitted via tears or through conjunctival secretions? And what are the possible mechanisms of ocular infections or viral spreading in the tears? So I think these are the three burning questions which I'm sure all of the audience will be kind of trying to listen. And let me try and see if I can help you with some of the answers. So as per reported in the literature, once again, as per reported in the literature, the things have been reported for the ocular manifestations are all on the ocular surface. Conjunctivitis like signs, photophobia, probably some blurring of the vision, people do say have been reported in the literature, itching, dry eyes, foreign body sensation, and there have been a case report of keratoconjunctivitis, though no signs of keratitis. It is mostly the keratoconjunctivitis, the purulent conjunctivitis, which was been reported in the literature. Second question, can SARS coronavirus be transmitted by tears and conjunctival secretion, and why do we need to know that as an ophthalmologist? And already Luis has alluded to that in his protocol about personal PPE and the infection control protocols, which has been set up differently at different hospitals, but by and large, the idea is to prevent spread to both the patients as well as to the healthcare workers. Carrying out certain outpatient procedures in the eye clinic, and as Professor Ongkin has also asked, one of the procedures to be carried out is the air puff. Is it safe to be carried out in the eye clinic or not? Probably will be answering that. Tear sampling as a potential adjunct, and we always put up grants saying that tear can be used as an adjunct for diagnosis of multiple things, and we've been using it. Here, can we use tear as an adjunct for diagnosis of SARS-CoV-2 infection? And how do we prevent and eradicate? One of the doctors has also asked, Dr. Doreen, about how do we treat some of these viral infections. What are the possible theories of mechanisms or the mechanisms for viral spreading in the tear? A, can be direct inoculation site from the infected droplets. B, possibly migration from the upper respiratory tract, very unlikely, but still possible. Hematogenous infections of the lacrimal gland and transmission of tears to respiratory tract via drainage through the lacrimal ducts, nasolacrimal ducts. So these are the possible mechanism of transmission, but these are again all the possible postulations. What are the ways we can detect virus from the tear samples or from the conjunctival secretions? So there are techniques which have been published in the past, and we can look into some of the techniques, and I'm sure Luis and all the other people will agree with me that there are different techniques and we can get different results, and the techniques are written here. But what have been commonly reported is a PCR technique to look at any of the sample collected by one of these three ways of taking the tear sample or the conjunctival secretion. There are very limited reports on the viral culture and CB effect, which I'll be alluding to in next part of my presentation. What are the contents of my presentation is the current evidence. So what are the current evidence? This New England Journal Medicine paper has been making waves with 0.8% being reported as conjunctival congestion, noted in 9 out of 1099 patients. There was no conjunctival swabs or tear sampling was done. So therefore, we do tell residents that read all this paper carefully. So again, in this paper, there have been conjunctival congestion being reported, but without much of conviction whether those were conjunctivitis. Likewise, in paper in JAMA, there were 2 patients who were positive conjunctival swab, and in Science magazine, it was reported 1/3 of the hospitalized patients had conjunctivitis. So this is quite different than what has been reported in JAMA ophthalmology paper. Then the single case report, very nicely documented and really a beautifully documented case of 30-year-old male with bilateral acute follicular conjunctivitis. And he got this at 13 days after the onset of viral fever. So this has been documented very well. And then there was a positive conjunctival swab, but this is just a single case report. Now I'd like to really thank Evan if he's here. And he's really inspired me to get this thing going with David Lai and our group at NCID. And this was on 23rd January, we started our journey about looking at the tears and the virus can go. And Ivan came from NUS, and then we started looking into this project. And we did sample 20 patients, but the data has been reported about 17 patients because 3 patients we could not get much of data. And therefore, for the 17 patients without any conjunctival congestion or without any conjunctivitis, the tear sample was done at different time points. So here you can see in the nice table drawn by Evan is where the tear samples was done at different time points. I had my own challenges to go to the COVID positive patients and collect the tear sample, but none of the patients we can get any viral from the tears using the thermal test strips. So as of now, if Ivan, you are listening, we got the second letter to editor. I'm sure there will be more letter to editor will come. And that's the second letter which we need to address is the technique right, or is your sampling right? Is it really negative? So those are the questions being asked. To put that into perspective, as the title of this today's seminar says, of ophthalmology perspective is, what do we know from that? So to discuss, many subjects who were tested PCR positive may not have ocular signs or symptoms, and likewise other way around. So this slide I picked up from another paper published in JAMA as a report, and which says about bronchoalveolar lavage fluid, pharyngeal swabs, bronchoscopy, breast biopsy, feces, sputum, blood, nasal swabs, urine. None of them has done sweat or tears. Whether it is really convincing whether the tears can be a source of transmission. From this particular, at least 20 hospitalized patients, the tears was not done. In this case, we don't know really. So it brings us to for and against debate. For, we do know that there have been some cases reported, but against, is there a real causal relationship between the ocular signs and symptoms secondary to virus? Or is it just the conjunctivitis kind of signs? Or is it really a conjunctivitis, which we call it as an infective conjunctivitis? We don't know. Probably yes, it is there. But right now, we don't know whether it is related to virus. And patients with positive conjunctival swabs had no ocular signs or symptoms. Again, can it be spread through the tears? We don't know. And then people have been talking about ACE2 receptors, and we have been we thought about looking at it, but we could not look at it because of different logistic challenges. But we really don't know whether the ACE2 receptor is expressed on the ocular surface, but we do know that it is there in the posterior tissues. So the possible theories which can be there for the congenital congestion, it can be infective conjunctivitis secondary to virus, but it can be also non-infective conjunctivitis, or just a conjunctival congestion, or a chemosis because of the underlying systemic manifestations secondary to renal failure or carbon dioxide retention, as we have written a letter to editor in JAMA Ophthalmology. And likewise, it can be secondary to inflammatory response in the body. So to conclude, it can do present as follicular conjunctivitis, as been documented in the single case report from British Journal of Ophthalmology. It can probably transmit through the tears and conjunctival secretions, but we haven't been able to group any PCR positive from the conjunctival swabs in patients, asymptomatic patients. So we really don't know. And further research is needed if we want to propose a mechanism of it. So this is a preprint review or preprint thing from animal studies done where they have done an ocular conjunctival inoculation of the virus to see whether the virus can get transmitted. Very beautifully done for 5 monkeys, and then they've really shown that it can get transmitted. So to conclude, we need to have a dedicated ophthalmological assessment, and some of us are already doing it, but we do need to ramp up our efforts to see these patients with all the different precautions as been told by previous speakers. we need to define what are the ocular manifestations and differentiate infectious conjunctivitis from non-contagious ocular manifestations of COVID-19. And we need to probably think about doing studies from the patients coming to the eye clinic with conjunctivitis without history of COVID positive. And is conjunctivitis the first manifesting sign of it? I really do not know. With that, I like to thank Leonard again and the college for giving me the opportunity to speak. Thank you, Leonard.
Thank you, Rupesh, for that fantastic overview of ocular manifestations of COVID-19. Well, it's now time for the question and answer this session with our panelists. We will address the questions that have been brought up in the Q&A option, but you may still continue to submit further questions using the Q&A option at the bottom of your screens. Just give me a moment while I just bring up the first question for our panelists. The first question was about air puff tonometry and whether it still continued to be used at Tan Tock Seng Hospital for all patients. So can I just bring this first question up for Dr. Louis Lim to answer?
Yes, thanks for that. As far as the question goes, in Tan Tock Seng now, we actually have stopped all air puff for all patients actually.
Okay. There is a fascinating question here. This question is, how do we treat COVID positive patients with conjunctivitis? I've seen some cases, but not sure what to prescribe. Maybe I'll pose this question to Dr. Rupesh first, then subsequently to Dr. Lewis as well.
Thank you, Leonard. Yeah, we will probably go ahead with the same treatment as we do for other viral conjunctivitis. Definitely, the systemic treatment is on for all those patients, whatever has been recommended if those patients are COVID positive. Secondly, the local ocular hygiene as we do it for viral conjunctivitis. And I will recommend to give antibiotic to prevent secondary infection and some tear lubricants for symptomatic relief. But there is no specific antiviral which I will be probably recommending at this stage because we really do not know which will work. I will probably, that will be my kind of recommendations for treating possible conjunctivitis patients in this kind of COVID pandemic.
Okay, thank you, Dr. Rupesh. Dr. Lim, would you like to say something about the treatment of conjunctivitis in COVID-19?
Okay, so currently, like what Dr. Rupesh has mentioned, there's no definitive treatment per se or any definitive antiviral treatment with regards to COVID-19 conjunctivitis. Personally, I just saw 2 patients in the COVID-19 ward yesterday, and we actually had 2 positive conjunctival swabs noted for such patients. Currently, we are treating them conservatively with copious lubricants as well as antibiotic eye drops to prevent any secondary infections. These patients so far are doing well. They are not worsening and they are doing very well. So I think we will continue to monitor these patients, but I think at this point in time, we will still mainly treat them as per any other viral conjunctivitis.
Okay, thank you. So the next question we're going to answer is, which specific cleaning agents are you using for your visual fields, OCTs, slit lamps, etc.? I'd like to pose that to Dr. Loon Sing Chi.
Thanks, Leonard. I actually spoke with the manufacturers of the Humphrey machine, and they actually, as mentioned during the talk, they don't actually encourage us to clean the bowl regularly because that will cause damage to the lining of the bowl. And I think similarly, there are other machines where there's a bowl as well, where there's reflection as well as the surface is important for the element for the testing to work. So that was a great concern for us, and we had a long debate with the ID physicians, Dale as well as Paul Tambaya in our institution on this. And basically, it sort of solved itself when the government basically mandated that all the patients that come wear masks. So that helped to obviate the issue a little bit. We clean the chin rest now, and they also suggested that we ventilate the room. So that's what we've been doing. Put large fans in each of the test rooms to help circulate the air, so that the air that may be potentially stagnant in the test bowls now can move a little bit as well. So that has been our solution to this problem of using these test machines. In addition to that, of course, we do the daily terminal cleaning as well.
Right. Thank you, Sing Chi. The next question we're going to address is really about PPE. And the question is, there seems to be some variations in the type of PPE being used across the clusters. Maybe I could ask Dr. Kaur to describe what PPEs are being used in Singapore National Eye Centre in the outpatient clinic and for surgery.
Thank you, Leonard. So I think the question actually came from our SNEC staff as well. As we can see from this series of talks, there is quite a bit of variation. At this point in time, at the eye center and as well as the satellites like in Sengkang, our doctors and all patient-facing staff will wear a surgical mask. It's universal precautions. That means hand hygiene in between every patient, cleaning down the slit lamp and so on. Gloves if you feel it's necessary. But we have not escalated to the point that we wear N95 masks for all our patients, gloves, gowns, or goggles. I think we have taken the stance that with the screening and so on, we've been able to sieve out most patients that, we hope that we'll be able to sieve out patients that are at the risk of developing COVID-19. We have also put in place other measures, safe distancing, the breath shields, taking care to limit our time with the patients and limit the patient's time in the clinic. So that has been the sort of perspective from SNEC. I know obviously in Tan Tock Seng there's been a different calculation and NUH as well.
Sing Chi, would you like to tell us about if there are any other variations of PPE use in NUH?
Thanks. I think for the general clinics, we have been doing a rather similar thing, which is for the average patient who comes in, we will just have masks. We don't actually wear gloves as a rule. One thing we have to note is sometimes we be cautious about these because there's a tendency to wear gloves for some people at least, and then they don't change the glove, which tends to be worse than if you after every case, you wash your hands vigorously, or even for every maneuver you do, you go and wash your hands. My hands are really dry now and you moisturize them, but I think it's better that way than to wear a set of gloves. We also have patients who have more suspect, then we take them to a separate isolation area and we put on PPE for that. I think for OT-wise, we mentioned that for those aerosol generating cases, we follow the guidelines which were adopted from AAO. And we will wear the N95 and so forth. And the rest of the team will leave the OT during the time if there's any intubation as well. Otherwise, for a general case, we've been wearing the surgical gowns, which is a form of PPE, as well as a surgical mask.
Right. Thank you, Sing Chi. One other question that is being posed quite frequently is about tele-ophthalmology or video conferencing. Can I ask Sing Chi again whether NUH has taken any steps towards tele-ophthalmology or communication for treatment purposes? Actually,
yes, we've been, first of all, I think there has been a circular that has gone out that insurance-wise, we are covered for this telemedicine as well. And that is an important detail. We've been using the good old telephone for some of the teleconsults for basic cases, although I would hasten to add that this should be carefully filtered by a consultant to make sure that they understand what are the kind of cases, because there is a real danger of things turning on its head if, let's say, the patient doesn't tell you the exact signs and symptoms or withholds information and then later comes back. So after every consult, we do document whatever we've done on the teleconsult, and it's still a very selected, filtered ones. The virtual consult is probably where I think more efforts can be concentrated, because right now I think to achieve, for example, a Weibo's excellent photograph, it still takes a bit of challenge, and not everybody can give that kind of photograph. But I think this is a catalyst and the right time for this sort of technology to be developed further post-COVID, not just in COVID, but to get more sophistication, better cameras, and we can do this in future.
Right. I understand that SNEC is actually quite advanced in this video conferencing area. Maybe I can pose the same question to Wei Boon as well.
Well, in terms of conferencing, yes, but in terms of tele-ophthalmology, in terms of telemedicine, I think we, like most of the centers, are still finding our way. We have started some trials in tele-collaboration between, for example, doctors and the A&E. So we're holding a small trial now in Sengkang, where the A&E doctor uses a slit lamp with a smartphone attached to it to transmit that information to the doctor on call. We're giving it a try to see that whether we can communicate that way, because it gives us real time. The doctor can speak to the patient and to the A&E doctor at the same time, as well as to get images off the slit lamp. But in terms of tele-ophthalmology, that means a doctor communicating with the patient, we haven't really gotten to that step yet. There are still a lot of concerns about getting relevant information from the patient. I think if there are any trials more in terms of just telecommunication, basically speaking to the patient, having a general look at him, and maybe more for education and counseling rather than for actual consultation.
Okay, thank you. There's a question that's come in. When do you expect the conjunctival swab to be positive for COVID positive cases? Can I pose that to Dr. Rupesh?
Sorry, Leonard, it was a bit clear. Sorry, Leonard, can you come again?
Yes, when do you expect conjunctival swabs to become positive in a COVID positive patient?
Thank you, Leonard. Basically, there are studies which have been done, and some studies have shown it can become positive between 12 to 14 days of the symptoms. But I think I would like to counter argue here is we really do not know when this patient, so you're talking about when the patient starts getting symptoms of fever, and by the time he got a throat swab positive for COVID, so are we talking from that time or we are talking from the symptoms? But again, the different reports have come up differently. There is a in the print in ophthalmology, there is one article which is coming up. I think it is published ahead of print, and it is showing in second day or third day you can get positive. In the letter to editor which I got this morning from ophthalmology, they said you should do it within the first day, and because I have done it from day 3 to day 17, they said and you cannot get positive because you did it from day 3 onwards. They said because if you would have done it day 1, I would have got it positive. That's the question. The BJO paper says it is on day 13. So there are a lot of variations here. But I would like to again challenge here is we do not know if it is just a COVID-19 patient without conjunctivitis, does his tears or will have any kind of virus which is positive there. Here we're talking about the conjunctival secretions which is coming up from the swab, about whatever reports are there. So we are not talking about the tears only. Yeah, thank you.
There's a related question. Has any virus been detected in the aqueous or maybe even vitreal fluids, Rupesh?
Yeah, that's again a very challenging question. Yeah, when I was very ambitious of putting up a grant on doing a retinal imaging of OCTA and looking at deep retinal vascular layers and all, and that was the question asked, how do you go inside and check the photographs? So again, it is even more bigger question, and there are not even a single report right now who has been able to poke up a needle into the anterior chamber or into the vitreous humor to get a fluid there. But I'm sure there will be some people looking into it. But right now we could not gather that courage, and I don't know whether there is a Chinese group, have they done it, or any group in US if they are doing it. But as of my literature review, it's not been reported about the virus from intraocular specimens.
Okay, I think we have time for just one last question. The question is, if a patient has had COVID and recovered, I presume that's something that we're going to see more of in the future, will you charge him or her to the isolation route to examine like a suspect case? Maybe I'll post that to Dr. Dr. Loon, would you like to answer that?
Thanks. I think one of the things about this particular disease is it's an evolving condition. First, we thought that there's fever, and then now it has asymptomatic patients. So you have a lot of these patient X people going around. And one other thing that's very important now is most of the transmission so far has been via fomites, and it's not an aerosol disease like some of the other viruses. So the information even when we share at this meeting is going to change, I would say. So I would still treat these patients with caution. If necessary, examine them in the isolation rooms for now, because we really don't know whether or not there's herd immunity. And I think there's already been some discussions that one infection doesn't give you immunity, and these patients should not be assumed to not be able to transmit the virus again. So at this stage, I would say we would just have more caution. And if later on we have more facts that once infected, you're no longer infective, then I think we can issue the warning to treat them as per normal. But for now, as things are very unknown, we should just be a little err on the side of caution.
Right, thank you, Seng Chi. Well, it's now past 7:30. This brings us to the end of the question and answer session. We have now come to the end of our live webinar on COVID-19 perspectives in ophthalmology. We hope you have enjoyed and benefited from the discussions. It only leaves me now to thank all the speakers. Thank you all for taking the time to join us. And we wish you a great evening ahead, and stay safe, everyone. Thank you.